Let me introduce today Dr. Rashmi Advani. It is such an honor for her to introduce her because unfortunately for some unknown reason she was on the East Coast for some years, and finally she's here with us. And this is our 9th year, as I mentioned before. So we anticipate 10 more years of this with you. Yes. She is an amazing woman. She does everything, but your passion to some extent in the bariatric endoscopy. And she's going to tell us how to do the endoscopic suturing the right way. Please.
Awesome. Thank you, Dr. Riker, and thank you to AWE for inviting me to do this excellent demonstration. I have Angela, the nurse here, that's going to be helping me show you how to actually utilize the device properly. So just to kind of start off, if I can help zoom in here, this is the endoscope. The endoscope that you could use is either a dual channel scope, a 2T scope, or you could use a single channel scope with another device called the NXT device. But this device is called the Gen 2 device, and this device is designed specifically for a dual channel scope. Now, in the dual channel scope itself, the way to actually mount the device is really crucial, and so this is something that you have to also educate your team on, is that the device itself, the bracket goes here, so you kind of almost mount
clip it on, right?
Yeah, you clip it on. So it has a little bit of a notch here, so you kind of angle it upwards, let it hit the notch, and then anchor it down. And that's kind of how you mount the device. You have to make sure that the cable is actually straight all the way down the endoscope, and so the end caps positions straight on the endoscope. And if I can actually turn off this light, just so you can zoom in a little bit here, this is the end of the endoscope where the end cap is fixated, and the larger channel is where the actual entrance cap is situated. This is the needle itself, the needle body, and this is essentially where you are opening and closing the device to transfer the suture back and forth, okay? Now the next phase of this, and I usually like to do a dry run before I even enter the patient, is I ask Angela, if you don't mind, this is the anchor exchange catheter that she's going to actually mount the anchor itself that's attached to the suture. So if you don't mind clicking it, so you'll feel like a click, and then essentially you just kind of lift it up at a 45-degree angle, and it should kind of naturally come out of the packaging.
So you don't want to pull too hard, right?
So exactly. You don't want to pull too hard, and you kind of want the actual suture to naturally come off without you actually manipulating it much. And then outside of the patient, I'll bring the endoscope here now. So the channel that you're going to be working with is the one that's closest to you. That's a larger channel of the two. The second channel actually has the helix, which I'll show you in a bit. Now, the way to actually ask your tech to hand you this, this tool is that they're kind of supposed to hand it to you like a rainbow. So can you hold it like a rainbow? And that is supposed to help reduce the wrist load for you.
And do you hold the string as you load?
Yeah, so I almost naturally hold the left string just to kind of keep it out of the way, so it's a little bit more straight. And you can even ask your tech to hold the string with some back tension. So can you hold some back tension on the string so it's straight on the actual string? Yeah, perfect. So that way it goes in straight and you're not creating any loops within the channel.
Now, here comes important debate question. Do you have it open or closed, the biopsy channel valve?
So I usually keep it closed. I like my insufflation to be
adequate.
Yeah. But you know, I've seen people kind of do both. Usually if you use a cap, I prefer to use lubrication because it just makes the device a little bit more easy to use while you're in a patient. But here, so what I usually do is both parts of this tool are advanced, and then naturally I take the string and I kind of move it out of the way so I can continue so they can release the string, and then they can just continue holding this at a rainbow until we get to the end of the device. So I'll turn the camera on, and before you even go down, if I can even point you over to the actual screen. So I'm going to keep this device open because when I advance this catheter with the suture, there's a chance of you kind of banging up against that needle body, and you don't want to do that. You want to keep it open and then advance it all the way. So you see over here, now this is my anchor exchange catheter that's holding the anchor, and the anchor is attached to the suture. So this is all the nomenclature for you to learn beforehand so you can actually have the same sort of consistent language in the room with your team. Now, the most natural thing I also like to do is create a little bit of slack. So the way I create slack is I advance the catheter and I abruptly pull it back. So there's a little bit of a loop that gets created in that, and you bring it back such that you don't see it any longer in the actual receptacle, the anchor receptacle, that's what that's called. So you close the handle, and this is how you manipulate the actual device to close that handle, to close the actual needle body. So I'm going to do a test run by exchanging the anchor back and forth. Now, I consider the anchor to be like a soccer ball. That's now in the era of the World Cup.
Oh, that is such a good
idea, right?
Oh, I didn't even think that. That is the way to go.
It's appropriate. So the anchor itself that's attached to the suture is kind of like a soccer ball that you're transferring from player one and player two. So I'm right now, the suture that's on the actual cable is player one, and player two is the actual needle body. So player one is going to meet player two, transfer the ball, but it has to actually be received by player two. So the way to actually release it to player two is you press the blue button to release the anchor or the soccer ball. Now player two has it, so we're great. So player two can now actually play with the ball.
Wow, I'm going to steal that. I'm sorry. When I explained how to do it to my fellows, that was beautiful.
Thank you. And so, now what I like, so now that I've tested that it can go to player two, I'm going to test it if it can go back to player one. So player one has to meet player two. So you advance the catheter, you feel the click, and all you need to do is actually just pull back. Okay? And that's sort of how you just transfer from player one and player two. Now, I'm going to go into the patient, and it's really up to you if you want to keep it loaded or not loaded. Now, actually, one last thing is the actual helix. I think many people have seen what the helix device does, but just so you're out of the patient and I could show you.
Yeah.
So this is advanced to the second channel. Second channel is smaller than the first channel, right? And so this is also your suction channel. And this is important during the procedure when you're kind of cinching and going to the next suture, is how you actually maximize your suction. But for this purpose, the helix is in this channel, and you can ask your team to actually push the helix out. So Angela, push the helix out. And so that's the actual screw that goes into the tissue that you grab to bring it towards you so you can get that nice full thickness bite, right? And then so you educate your team on what a full turn means. So a full turn is 2 half turns. So naturally your wrist only goes halfway. So Angela, can you do 2 full turns for me? And can you show the camera over to Angela's hands?
Nice.
Right. And so that's 1 full turn. So she has nice flexible wrists that can actually go the full 360, but sometimes some people may just do it halfway. So you just see what that means to both of you. So she did 2 full turns, and that naturally turns the screw. Perfect. So helix back. So helix back is just a pull back on this blue tab. Excellent. So now we're ready to go into the patient.
All right. And I noticed you closed the jaws as you were going in.
Exactly. So if any of you doing this, just one more thing, if I could actually show it to you, is when you go into a patient, if your actually, if you could hold that, if your device is open, where your handle is open, you see you have additional real estate that you're actually not capturing on camera. So by nature of this, if you advance it into the patient, you can actually create tears and lacerations and perforations because you're not actually seeing this portion of the scope. Case in point.
That is behind.
It's behind. So it's your duty and also your team's duty to make sure that this is closed when you're entering and exiting the patient. So
all right,
we're going to close that. Excellent.
Team one and player one and player two.
Player one and player two.
Both closed. Yeah.
So one more little tidbit that is not reflective here because we don't have an upper esophageal sphincter, but when you're advancing this device, you want to make sure that you stay parallel to the tongue and parallel to the piriform sinus when you're entering the UES. And that's to help you reduce the risk of tears and perforations. So now we're naturally entering the patient. This is the esophagus, so we're going in. Our patient pig's stomach.
Yes.
So perfect. Okay. Now we have a defect here. So overstitch can be used for many things, and today actually I'll be showing some cool cases about how we can apply this broadly even outside of bariatric endoscopy. So all the time, if you've noticed, I've kind of kept the suture away from this apparatus. Now let's start. I'm going to advance player one, and now player two is ready to receive the ball. So they received it, and now we're ready to go. So this is the load. You've loaded now the suture, and you've loaded it onto the needle body.
So what are the common mistakes people make at this step?
Yeah, so some of the common reasons why that may not happen is, say you didn't feel the click actually. So
yes.
Say like you advanced the catheter, but it's like that. It didn't actually.
There's a
space.
Space, yes.
There's a natural space. So you want, I say that this device is 90% feel and 10% visual,
yeah.
Because you want to feel how that exchange happens. So advance the cable and make sure it kind of notches on. You'll feel that little click on your finger. And then the other natural mistake is some people may forget to actually press the blue button, so they start opening the needle,
without
the
transferring player one to player two.
Yeah, player
Here we go.
Exactly. Player two still doesn't have the ball because we haven't released the blue button to player two. So I'm not going to do it all the way, but I want to show you what a stalemate looks like.
Oh no, they're not.
So you see that?
Yeah, that's not working.
So it's not working, and you can naturally almost bend the anchor as a result of this. So I'm not going to go all the way because we want to show you how to take good full thickness bites. So I'm going to close it back. I'm going to release it to player two, and now we're going to open it. Okay, so now we're ready to rumble, right? Okay, so my general approach to taking care of defects are left to right, top to bottom. That's the natural flow of the device, and will actually help you reduce any sort of crossing of sutures, which I could show you that too. So what I'm going to do is I'm going to ask Angela, can you push out the helix and rotate it 2 times, please? And so I like to work a little bit from a distance because that gives me sort of a roadmap of what I want to target next and how things are looking along the way. So I'm going to pull this tissue. So that's a pretty good pull of the tissue. If you
for
want,
the pig stomach.
For the pig stomach, right?
Yeah.
Usually it's like 6 turns in the pig stomach.
Yeah.
Sometimes what I also like to do is while I'm pulling the tissue away, I'll ask for 1 or 2 more turns. So Angela, can you do 1 more turn for me? Yeah, so that gives me better,
premature, we were premature.
Right.
We're a little premature happiness here, yes.
Okay, can you give me 3
right.
turns, Angela, please? Actually, 4 turns, please.
Yes.
Give me
but
4
in a
turns.
patient, we should be okay with that.
Yeah.
Especially in the colon if you're doing closure after.
Exactly. So I'm going to pull this forward. Angela, give me 2 more turns, please. Okay, excellent. I love that. Okay, so what you want to do is actually bring the tissue all the way towards you, look downwards, so that way you can actually predict the path of where the suture is going to go. So this is a defect closure. All I really want to do is grab the mucosa on the left and bring it through the defect in the center, right? So let me bring this here.
And this technique requires movement because
Yeah.
I see you. I don't know.
Naturally, I'm moving my body.
You're moving your body a lot, and we don't realize that. It's not a stationary technique.
It is not. You're basically dancing with the scope. So if any of you do waltz, this is kind of similar. So I look down at the same time and I close the handle. Now player one is ready to receive the suture. So the way they receive the suture is like we showed before. You advance the catheter onto it, you feel the click, you feel that notch. And this is what I mean by actually feeling the device. You feel that sort of click down and you're like, okay, now I'm ready to receive the anchor, the suture, and you pull back naturally. And when you see that kind of movement in the tissue, you're pretty sure that it's transferred back to player one. I open the actual handle and I pull back. And what I'm trying to do is now show you that unhelix. Perfect. So the number of turns should reflect the same amount of turns that you got there, but sometimes they may not always be the case because you're kind of rotated. So just both of you need to communicate. So you could see actually the suture having gone through the tissue here and through the actual defect, the corner of the defect. So let's land a second suture here. Now sometimes what happens is you can bend this anchor down here. And so if you want to salvage it, sometimes you can actually try to close the needle body to try to meet it.
Kind of in the air, like a stitch in the air.
Yeah,
in a way.
stitch in the air. So if it's not coming together when either are at their individual locations, then you can kind of advance the catheter slightly to see if there's a way for you to actually marry the two engagements there.
What to do if they're really heading for divorce and just not really married?
I love all of our analogies.
Yes,
here.
exactly. I don't know where that come from. Let's say there are situations where it's just either the needle got bent or the driver. What to do?
Yeah. So if it's something that you can actually just drop.
Yes.
Into the patient and cinch over it, then I would.
Then you would just.
Then I would just do that.
Not waste your time.
I would not waste my time.
Yes.
Sometimes you could actually take another sort of the forceps through the second channel and try to get it onto the actual cable or the needle body, but a lot of times that may be time consuming, so sometimes you may have to just make that risk benefit, whether to just sacrifice whatever suture you've already kind of put through the patient and then cinch it and then kind of march on forward. So
basically, most important, they should see the recording of you doing this and make sure that nobody connecting player one and player two until the player one is fully retracted.
Exactly.
And it doesn't get bent.
Exactly.
So I think what we're going to do, for the interest of time, maybe we should cinch and demonstrate that. Would that be okay?
Awesome. So I'll just take one more bite so I can properly show there's a closure. So now player two has the anchor, and what I'm going to do is, can you give me about 3 or 4 turns, please? Okay, stop here. So you see that twisting of the tissue? We kind of want to avoid a little bit of twisting of the tissue, but on the pig stomach it may,
It might not always cooperate.
It might always cooperate. So let me see if I could bring this up. And I'm going to turn my body right to see if I could just capture.
Oh, look how that is. Were you a dancer at some point?
Yes, I was.
Oh, here you go. How did I know that?
You have a very good intuition about you, Dr. Raker.
Yeah.
Okay, so I'm just going to, now again, it's all feel. Okay, can you unhelix here, please? And so we should be now appropriately taking our second stitch. Perfect. So we've taken our second stitch and we're ready to cinch. Now, when you're ready to cinch, you want to make sure that the actual anchor is on player 1. You release it. And at this time, actually, what I like to do is, because they're going to get the cinch on, I like to have this come out of the patient as well, because I could use this channel to lavage and suction.
Aww.
That's not the case necessarily with the NXT device, because you have a third channel that actually shows the area where you can suction. So, but specifically for
demonstration.
Yes. We pull this out, and then so this, if we can.
Now, here's another thing that frequently happens, that suture driver falls out, or you can, let's be honest, my eyes is not what they used to be. It's not always too easy, although.
I'll show you, yeah, thank you. Okay,
how do you
navigate that?
How do you navigate that?
Sure, yeah.
Although Angela got it through with no problem.
I know, she was like,
nothing, yes.
She already got it. Okay, so Angela perfectly did this, but what you see here there are 2 circles here. You can put the suture through any of these circles, advance it through, okay? And what I usually ask my team to do is almost pull it like an airplane taking off. So all these analogies, right? So,
it's always good. That's how we remember it.
Yeah, so you pull it like almost at a 45-degree angle, and that naturally pulls the suture through. Now, if I were to take it out at this angle, there's a chance of it breaking, there's a chance of it dislodging. So let's just say, let's screw ourselves a little bit. So let's pull it out and let's say, okay, everything came apart. Oh, man. So what I usually like to do is, if this is not broken, you can actually advance this through the top into the
little hole back.
Little hole to recapture. Or just for time's sake, what I usually do is I create a little bit of a bend here, and it's about, I would say, like a centimeter or centimeter and a half. And there's a little bend here. I don't know if you can appreciate that, but I just did that with my nails, my well-manicured nails. And you advance it from the top here through the entrance, and so the suture, you see how it kind of comes out this here? So this is how you can salvage the suture. Now, this is usually designed for younger eyes, but if you have a young person in the room that can look at this,
or the glasses,
yes, this will help. So, Angela, if you could hold this. I'm going to grab the scope again. So again, she's doing it perfectly. She's giving me back tension on the suture. She's handing me the catheter like a rainbow. So you can give me more back tension on the suture, please? Okay, so I have the suture. Thank you, Angela. Okay, so now we're going to go back to the action. Both players have scored.
All right.
It's a draw in the World Cup. USA?
Yes,
Switzerland?
USA, yeah, that's right.
USA? Okay, good. So usually, again, another aviation terminology, I like to land the cinch like an airplane onto the tissue. And so usually the cinch is actually where you take your first bite, okay? So you want to drive it towards where you had taken your first bites in order to create enough tension so you can adequately suture.
And do you advance until you see those, whatever those ribs or whatever you call it?
Those rings, yeah. Ribs, rings. Probably I do 2 or 3, I could see. So naturally, if you could look at my hands right now, I've naturally just sort of moved the scope like a baby. I've cradled it like a baby on my left forearm, and it liberates both of my hands to actually do this little dance at the channel. And the dance is, you advance the cinch and you pull back on the suture, and that's how you kind of create that tension. And it's reflected at what you see here on the screen. So you advance the cinch and you pull back the suture. See?
Oh, well, it came to you.
Well, it came to you, yeah. And give yourself distance. You know, you don't have to be so right up against the tissue. Kind of like a person you're dating. Don't be too much on them.
We're really marriage now we're today.
It applies to everything. Okay,
yeah, that's right.
So perfect. So now that I feel like I have a good enough tension on the suture, I'm going to ask Angela, okay, can you release?
Oh, look how she did that. She beautifully. She pushed it out. I didn't
Yeah.
even notice that. All right.
Exactly. And so she's naturally using her two hands because no matter how buff your tech is, you need equal force on both sides of the cinch in order to properly sever the suture. So Angela, can you please cinch?
There you go.
Excellent.
That's it.
Nice.
Look how beautiful it is. It's not loose at all.
Not loose at all. There
That
you go.
was a beautiful demonstration from
Thank
both of
you.
you. Thank you so much. We learned a lot.
Thank
Player
you.
one and player two.
Player
Here we
one.
go.